Hi, my name is Laura Atkins. I'm an MSN student at LCU. I'm also a registered nurse and a donation clinical specialist for live gift organ donation. I want to talk to you today about organ donation, but I want to look at it from the nurse's perspective. So our objectives today in this video are to discuss the advantage of early referrals, the historical perspective of brain death, to discuss the difference between cardiac and brain death, how to pronounce brain death, the evaluation of potential donors, and the pathophysiology of brain death. We also want to discuss donor management with associated hemodynamic, hematological, and endocrine considerations for optimal organ function, how to prepare for the operating room, and then spend just a little bit of time on our bereavement program. So early referral is very, very important because it allows us to do a lot of things and get a lot of information before we approach the family for donation. Once a patient meets criteria, this allows for us to come out and do an assessment of the patient. We review the chart. We discuss the plan of care with the nurse and the attending physician. The big thing for us is knowing what the family dynamics are. Who is the gatekeeper? How does the nurse or the physician feel that the family will be, how approachable they are. Brain death itself is very complicated. The bottom line for you as the nurse is to know that Life Gift is never going to ask for this. This is a decision and a clinical exam by a physician. Brain death can only be pronounced by a physician and cannot be pronounced by a nurse practitioner. So we go by the Harvard guidelines that were set up in 1968, and you can read more about that in the Texas Anatomical Gift Act. So brain death is defined as the cessation of all function of the brain, including the brain stem. It's irreversible, and the exclusion of reversible conditions must be documented by an MD and include the date, time, and pronouncement. So for brain death testing, there has to be clinical test, an apnea test, an EEG, which we don't love because they're varied but can be used, and the gold standard is always a cerebral brain flow test. So a clinical examination, which we are hoping that the nurses are doing every time they do an exam of their patient, but will be performed at the bedside by a physician. We're going to look at their pupils, corneal reflexes, oculovestibular reflexes, facial motor response, are doll's eyes present, do they have a cough and a gag if we suction them. We're going to do an apnea test. The bottom line for the nurse is that we want to see if taking the patient off of the ventilator and a buildup of the CO2 will cause the patient to take a breath. If they do, then the patient is not going to be considered brain dead. An apnea test helps us determine that. Usually what the physician will do is do clinicals and an apnea test, and if either one of those tests are questionable, then they want to do a confirmatory test, which the cerebral brain flow is considered to be the gold standard. So let's talk about some of the physiological consequences of brain death. First, there's an autonomic storm, so you're going to have circulating catecholamines, the blood pressure is going to go up, the heart rate is going to go up. Then they're going to separate, and you're going to have what's called Cushing's triad. Herniation finally becomes complete. This can take a short period of time, or it can take a long time, like several hours. Hemodynamic changes include a drop in cardiac output, and this is secondary to ventricular dysfunction, vasodilation, decrease in the SVR, or left ventricular failure, secondary to an increase in workload. What are some of the consequences of brain death? There are endocrine changes. You don't have brain flow, you don't have function in the brain, and so you're going to have some things that happen. So DI, diabetes insipidus, hypothermia, coagulopathy, and neurogenic pulmonary edema. Hypoxia is going to be one thing that is a big concern. So once brain death has occurred and the doctor has declared, time is of the essence. 62% of people will suffer cardiac arrest in 24 hours and 87% in 72. So we're going to look at donor suitability. First, we're going to look at the cadaveric donor. We're going to obtain full social history. This is required by AOPO, and AOPO is the organization that kind of oversees all of organ donation. So the things that we're going to look at is a current hospital course, everything, all the medications, the treatments, any surgical procedures that they've gotten. How old are they? Are they female, male? How big are they? What's their height and weight? We're going to look at the cause of death. Was it anoxia, CVA, MVA, gunshot wound, and any past medical history that can tell us whether this patient is going to be suitable for organ donation. So we're going to look at external signs of cardiac function. We're going to look at peripheral pulses, skin temperature, edema. We're going to do an EKG. We're going to do a 2D echo. And if anybody is over the age of 40, they're going to the cath lab for a cath. We're going to look at lungs, how long they've been intubated. Were they intubated in the field? Is it traumatic? Did they have any kind of injury? How do their breath sound? What do their ABGs look like? We're going to do an O2 challenge for lung placement, and this should be an FiO-PaO2 ratio of 3:1. We're going to look at their kidney function. What's their BUN and creatinine? What was it at admit? Has their function decreased? We're going to get a UA, a CNS, and look at any kind of issues that they might have kidney-wise. We're going to look at their liver function test. We're going to do those every 4 hours. What's their PT, PTT, AST, ALT? Their nutrition status. Are they overweight? Are they underweight? Do they look okay? Their nutritional status. Do they have a history of hepatitis? For the pancreas, we're going to look at the same information. PT, amylase, lipase, glucose treatments. Are they on a drip for glucose? For small bowel, we really only get small bowel for children, but we want to look at, have they had a history of diarrhea? What's their CMV status? So for the nurse at the bedside, goals of donor management are pretty basic. We're going to maximize oxygenation and perfuse the organs. We're going to use the rules of 100. So we want their heart rate to be 100. We want their systolic blood pressure to be about 100, and their urine output to be 100. Now these are not exact, but the rule of 100 is easy to remember for all patients. And you're never going to have a patient that's the same no matter what. So some of the things as the nurse that you're going to see that happens to a brain dead patient is they're going to experience hypotension. They may go into DIC. They may have DI, and most patients do. They're going to have hypothermia and experience hypoxemia, maybe electrolyte imbalances. So how do we fix these? Well, with hypotension, we want to look at what is causing the hypotension. Do we need to give them volume? Do we need to get their CBP up? Are they peeing all of their volume out? Do they have a blood loss? Do we need to give them blood? Do we need to give them a vasoactive um, medication like Levophed? Do we just need to give them fluid? Most of our patients are going to go on D5.5 with 20 of K. We're going to give blood if we need to give blood. If we need to give crystalloids, we may give crystalloids. We don't use colloids very much. We do use dopamine, Levophed, Epi. Those are some of the primary drugs that we use in donor management. Levophed is going to be the drug of choice. We don't use dopamine or dobutamine very often. Epinephrine in kiddos, and very rarely do we ever use neosynephrine. Goals of fluid resuscitation are just like anything else. We want their CBP to be 6 to 12, their urine output to be 100 or greater. Again, their systolic blood pressure at least 100, maintain their IO balance. If your patient goes into DIC, we want to make sure that we recognize that and we're going to treat it as needed. So those are things that they don't happen a lot, but if you take care of the fluid volume status, make sure that they're not cold, and treat anything that you need to treat, then your patient probably won't go into DIC. But if they do, you may give them FFP. We're going to check the calcium, make sure that all their electrolytes are okay, or make sure that the patient is warm. For diabetes insipidus, most all brain dead patients will have some form of DI. It may not be big, but it could be small. So we're going to start seeing polyuria greater than 300 cc's out. Their serum osmol will be up, their sodium will be up, and their specific gravity will be very high. We're going to give Solucortef, DDABP, vasopressin, anything that we need to do to control that, we're going to give. Hypothermia, bottom line is we're going to keep them warm, put a bear hugger on them. We want to make sure that we're treating it, we're aggressive. We just don't want the patient to become cold. Hypoxemia, this is an emergency, and we have to do everything that we can to prevent this. So we have to figure out what the cause is and try to maintain that balance. So there are going to be a lot of things that we may be asking respiratory therapy to help us with. Electrolyte imbalance, this isn't going to really be any different than the nurse in the ICU. Most ICUs have an electrolyte protocol. We want to make sure that we are replacing what we need as we need it, because what's good for the patient is good for the recipient. And you don't want to give somebody a bad heart, you don't want to give somebody bad kidneys, so we're not going to treat this patient any different. We want to make sure that everything is normalized to the best of our ability, and that includes electrolytes. So with organ allocation, it's very complicated. I'm not really going to touch on it a whole lot. UNOS is the United Network of Organ Sharing. They're the organization that maintains the list in regards to um, organ procurement, and it's just very complicated.